Hello, and a very good afternoon to all our viewers. Welcome to this brand new session of Dent-E-ssentials, where today we will be talking about peri-implantitis management. Peri-implantitis is an inflammatory response to infections in soft tissues and bone loss around osseointegrated implants. These infections are mainly due to spirochetes and mobile gram-negative anaerobes, or sometimes simple mechanical overload in case of implant failure. Changes in the gingiva coloration, bleeding, and probing depth of peri-implant pockets, and gradual loss of bone height around the tooth are important symptoms of these infections. Peri-implantitis management, thus, should be centered around detoxifying the implant surface and regeneration of the alveolar bone. To discuss more about peri-implantitis and its management in routine clinical practice, we have with us today Dr. Jasmine Crena. Dr. Jasmine Crena is a renowned and experienced periodontist and implantologist in Chennai. Presently, she serves as a senior lecturer at SRM Dental College, Chennai, and has a keen interest in periodontology and implantology. Dr. Crena has multiple national and international publications to her credit. It's an honor to have you with us today, Dr. Crena. Welcome. You may please share your screen and begin your presentation.
Good afternoon, everybody. And thank you, DocPlexus team, for this giving me this immense pleasure on sharing my PPT on peri-implantitis and its management. So today we will be discussing about an important topic, which as clinicians, which as students, which as day-to-day practitioners, as specialists, as consultants are very commonly facing. So that is peri-implantitis. So I will be talking on what is peri-implantitis, what is the biologic rationale, so the basic anatomy of the peri-implant tissue, along with that additional features on how do you diagnose the peri-implantitis and how we can manage it. There are so many methods available, so the management part also will be talked upon in short. So what is this peri-implantitis and where does it occur? How do we overcome it? So if we have to go to the beginning, so the peri-implant tissues, when they are inflamed, it leads to peri-implantitis. So what is this tissue that surrounds the implant? This tissue is nothing but it's comprised of both the mucosa, which is the epithelium and the connective tissue, and the alveolar bone, which is surrounding the implant. So when this is getting in, it leads to peri-implantitis. So when I told you about the soft tissue comprising of the epithelium, here when you see this structure at the outer end, this is called as the oral gingival epithelium. And when it dips down here, this is called as a sulcular epithelium, oral sulcular epithelium, this part. And this junction between the implant and this whole connective tissue part is called as the junctional epithelium. So this is the important histological structure we need to understand when we talk about peri-implantitis, because on and off, this is the structure which is going to get affected. That is why this is my first slide, to understand the histologic feature of peri-implant disease. Only when you know the histologic feature, we will be able to face the disease and correct it. Having known about the junctional epithelium, the oral sulcular epithelium, and the gingival epithelium, we will go to another important structure, which is called as the supraalveolar gingival fiber bundle. So this is a very, very important fibrous structure or a connective tissue structure that is seen between this apical extent of the junctional epithelium. Just a few minutes back, I told you about the junctional epithelium. So this part where there is an extension of the junctional epithelium till the crestal area of the bone. So this region is what is called as the supraalveolar gingival fiber bundle. So as the name suggests, is composed of gingival fibers rather than the epithelial part. So comparatively, it should be a little stronger structure because epithelium is a little softer tissue. When it comes to collagen fibers or the fibrous structure, it's going to be a little stronger. This zone, that is, this supraalveolar gingival fiber bundle has two zones in it. One is the inner zone, the other is the outer zone. So outer zone will be towards the epithelium and the inner zone will be towards the crestal part. This inner zone is around 50 to 100 micrometers and it is dense, but it is not as vascularized as the outer zone. The outer zone comparatively serves more functional purpose because it has more functional orientation of the collagen fibers. Also, it has a strong vascularity. So in this pictorial representation, what we can see is the outer zone, the zone B. This one is a zone B and the inner zone. So this part is the one which is taken. So the blue color part is your implant. This pinkish part little bit is your zone A, which is the inner zone, and the outer zone is there towards the implant region. So this part is going to give us an immense connection between the implant and the tissues. When this fiber bundle is compromised or it's not formed, it leads to implant failures. So first we spoke about the soft tissues. Next important landmark that we spoke about is the supraalveolar collagen fiber bundle. So please remember this throughout the session. So it will be helpful for you to know why peri-implant disease occurs. Next, coming to an important connection. So on and off, whenever we talk about implants, we talk about what is called as the direct structural and functional connection, which is called as osseointegration, as stated famously by our father of implantology, who is Brennan et al. As the definition goes, this tight structural and functional connection should be established in order to have a good long-lasting implant. So the implant survival rate very well depends on this process called as the osseointegration. Osseointegration, on the other hand, is very much dependent on the implant itself. The surface design of the implant plays a major role for osseointegration. That's why today we have different modifications in implants. Only when there is a proper connection between the implant and the tissue surface. You cannot change the tissue surface. So there are little modifications that will enhance this osseointegration. So apart from the tissue part, there are certain parts which you have to know on the implant, which could be modified on and off. And in your day-to-day practice, such modifications in implants should give you should also give you the right choice for the patient. So which modification will be better for which patient has always to be in the mind. Next important thing is this biologic width around the implants. So biologic width is nothing but the combination of the epithelial as well as the connective tissue component. This component is very important to enhance or to enable the formation of that bundle which I spoke about. So when the biologic width is compromised, it means that the supraalveolar collagen fiber bundle is not going to form. When that fiber bundle is not formed, there will be inundation of bacteria. There will be establishment of plaque around the implant surface. So when you're not establishing a proper biologic width, there will be problems in relation to formation of plaque. So this biologic width, as I told you, is composed of the epithelial part, as well as the connective tissue part. You should be able to maintain an altogether 4 millimeters of biologic width in order to have a long-lasting implant. So this is an experiment which was done long back by Berglund et al. when he had a very less biologic width. Okay, so there is a compromise in the amount of bundles formed. So here you have a tight collagen fiber bundle which is long enough to ensure that bacteria will not penetrate into this. So when the biologic width is compromised, cells become small. So this will lead to penetration of the bacterial microorganisms into the bone. This is how biologic width plays an important role in formation of or leading to peri-implant disease. So when you place an implant, there is a dynamic equilibrium that exists between the host as well as the microorganisms. So normally in the teeth, you know very well that you have the gingival sulcus where you have formation of plaque. Once this plaque forms, there's microorganisms and they multiply and they form a lot of colonies, they enhance, they multiply their colonies. And that's how there is a buildup of disease. So that equilibrium, when it is lost, so when the host and the microbial defense mechanism is lost, when the equilibrium is lost, there is formation of disease. The same thing goes with peri-implant diseases also. So when the sulcus is inundated with microorganisms and the body is not able to support its defense, then comes break in the equilibrium leading to peri-implant diseases. Not only that, the mechanical load also plays an important role. So along with a microbial component, a mechanical load component also leads to peri-implant diseases. So only when the host parasite is in equilibrium, also when the biomechanical part is in equilibrium, you will be able to enhance the survival rate of the implants. So once you have an implant failure due to some reasons, you need to categorize into two main problems. So you can either categorize them as biologic failures or you can categorize them as prosthetic failures. So biologic failures are, as I told you, from the host. So one side is the host tissue. The other side is the prosthetic failures. It could be the implant as such, or it could be the prosthetic components of the implant. So broadly, we categorize them as biologic failures and prosthetic failures. Under biologic failures, you can have either early failures or you can have late failures. Early failures occur within weeks to months, whereas late failures occur later in time. So does all the implant go in for failures? Maybe yes, at some point of time. So we need to categorize whether it's early failure and whether it's a late failure. So maybe I may be wrong, but over the period of time, we tend to, the prevalence of peri-implantitis, when we see there are failures which have been faced more or as the age of the implant progresses than not success. But in that success rates, when all of us tend to maintain that particular peri-implant health as well as our technique related issues, when we try to stick on to our standard procedures, then our failures will be definitely very less. So early failures occur because of improper surgical technique. So surgical acumen for placing implant is very important. Next is during your surgical technique, when you allow immense heat to form, it leads to bone necrosis. That could also lead to early failures. Apart from that, contamination of the implant surface, when you're not handling the implant carefully, when there is contamination of the wound site, especially when you have an abscess and sometimes when you place an implant and there is a contamination of the wound site, or due to any other reason. Next, lack of primary stability, which is around 35 Newton centimeter square, need to be maintained. If it is lesser than that and we are loading it, there is no primary stability attained, then we might face problems leading to early failures. Apart from that, premature loading. So posterior teeth, when you prematurely load, it might lead to early failures. Next, some of the reasons of late failures are probably because of infections over the period of time due to food lodgement or due to maintenance, ill maintenance of the implant, or sometimes because of overload can lead to late failures. Apart from that, there is something called as a non-infection associated biologic failure. So sometimes it will look good. There's no infection as such, but there can be failures because of certain factors like fibro-osseous integration. So when there is no osseointegration, there is fibro-osseous integration instead. So instead of the bone, the fibers are playing a role in integrating the implant to the bone. Then that will also lead to non-infection associated biologic failures. Apart from the pathologic overload of the bone can also lead to non-infection associated biologic failures. So this is a little older classification which I would like to say because it's a very, this is the most famous, and 1993 classification states that peri-implant diseases are the terminologies most commonly used are peri-implant diseases, peri-implant mucositis, and peri-implantitis. So this term mucositis and implantitis should click into our minds two important things: whether the disease can be reversed or whether the disease cannot be reversed. So when you talk about peri-implant mucositis, it is a reversible inflammatory reaction which occurs only in the soft tissue, whereas peri-implantitis is an irreversible process which will lead to peri-implant pocket formation and also loss of supporting bone. So these are some of the terminologies which you should know. When we talk about peri-implant disease, it's a collective term of both peri-implant mucositis and peri-implantitis. So here in this slide, I have put three important terminologies, which is ailing implant, a failing implant, and failed implant. So what are these three terminologies? They look similar, but there are three important parameters in this. One is soft tissue inflammation, the other is bone loss, the other is mobility. Okay, soft tissue inflammation, bone loss, and mobility. So an ailing implant is one where there is soft tissue inflammation. There is no bone loss and no mobility. Failing implant is one where there is soft tissue inflammation and also bone loss, but there is no mobility. Failed implant is one in which there are all the three. That is, there is inflammation, there is bone loss, and there is also mobility. So these are the three important terminologies which you should remember: an ailing, a failing, and a failed implant. And the three parameters are soft tissue inflammation, bone loss, and mobility. So with this, we'll move on to the next. So what are the most common etiology of peri-implant diseases? Literature states very clearly that the primary etiology of peri-implant disease is formation of bacterial plaque and biofilm. So this is invariably for the teeth and also for the implant regions. So these bacterial plaque, when they form around the suprastructures, around the implant site, around the implant sulcus, definitely it's going to lead to colonization of bacteria and later lead to increase in sulcus depth, leading to bone loss. So that's how peri-implant diseases start. Apart from that, there are some additive factors like if there is pre-existing periodontal disease, when there is smoking, or when there is diabetes mellitus, poorly controlled diabetes mellitus, alcohol consumptions, genetic factors, especially IL-1 gene polymorphisms, when the texture of the implant surface is very rough, when there is occlusal overload, when the amount of keratinized tissue around the implant is very less. Apart from that, any fractures of the suprastructural components of the implant, when there is a compromised alveolar ridge, any bone augmentation procedures which has to be done and we did not do it. Apart from that, any development of gingivitis, desquamative gingivitis like diseases, or any bisphosphonate medications which have to be taken by the patient. So all these can lead to failure of the implants, leading to peri-implant diseases. So the most common colonization by microorganism, as stated by Mombelli et al., is focoid to anaerobic flora. So this is the most common organisms. Mostly Fusobacterium species play an important role in causing peri-implant disease. So there was a very nice statement given by Hayes Mayfield et al. He said that patients with a history of periodontitis will show an increased risk for peri-implant disease compared with non-periodontitis patients. So even though patients have a lot of money when they come to you at the age of 45, and they have periodontitis, you should think about placing an implant in such patients. It's good the patient is interested in placing an implant, but if the patient has periodontitis, you treat it at that moment or you do not treat it at that moment, it definitely is a risk factor for the implant survival rate. Apart from that, one more important thing is there is a tendency for greater crestal bone loss and probing pocket depth at the implants that were placed in patients who suffer from aggressive periodontitis. That also should be noted. So aggressive periodontitis patients and pre-existing periodontitis patients are also increased risk factors for peri-implant diseases. So as I told you, the biofilms around the peri-implant sulcus will lead to a mixed anaerobic infection. So this anaerobic should give in your mind certain ways to treat the disease. So your broad spectrum antibiotics are the ones which will help you, and also some of the drugs which can help anaerobic infection to be combated is the one which you should focus on, and not a say a plain penicillins will not help us much. Apart from that, pockets more than 5 millimeters can also have be a very good niche for the periodontal or the peri-implant pathogens. Apart from that, if there is sporadic high number of Cryptostreptococcus and Staphylococcus, it also leads to peri-implant diseases, is stated in one of the literatures. So as I told you, genetic factors, there are studies which says that when patient is having an IL-1 polymorphism, it leads to peri-implantitis. So there are susceptibility tests right now which will help us to know if patient has IL-1 genetic polymorphism. So if it is there, then accordingly we need to alter our supportive periodontal therapy for peri-implantitis so that patient will not have compromise in the implant survival rates. Smoking and alcohol consumption also is equally stated to be very important risk factor, especially smoking more than say 10 cigarettes per day will definitely be a greater risk factor. So you need to motivate and talk to the patient accordingly. Also, alcohol consumption of more than 10 ml per day may also lead to increased bone loss around the implants. When you talk about occlusal overload does contribute to bone loss around the implant. So you need to educate the patient as to how much of load you can give. And you need to talk about the bite force so that patient can avoid biting too much on the implant regions. These are some of the studies which will tell us that where there is the keratinized mucosa is very less, and that also leads to peri-implant diseases. Apart from that, if there are any alveolar ridge defects, so when patient had a periodontal defect and you did not correct it, so see there is a buccal defect here, there's a defect in the bone here, and you had placed an implant over the period of time, there is a dehiscence formed around this region. So that's because of this periodontal defect which was previously existing. So this also will lead to exposure of the supracrestal structures, which will lead to peri-implant diseases. So desquamative gingivitis also, there are reports of autoimmune diseases and desquamative gingivitis diseases, which will lead to compromise in the gingival areas or gingival structures, which will lead to inflammation around the implants. So systemic diseases, there are a lot of systemic diseases that contribute to peri-implantitis, but the scientific literature is not very well evidenced in because ethical issues in placing implants in diabetes patients and in smokers, all have been existing for a long time. So literature is comparatively lesser. However, they are increasing right now because of studies which have to be done even in a diabetic patient. In our own team, we have taken up cases, or we have taken up a long-term study where we are involving moderately controlled diabetic patients, and we are seeing that certain type of implants do give us a very good outcome when the patient is also having a moderately controlled diabetes. So this part I have already spoken. When this equilibrium is lost, it leads to pathogenesis. So now once you know that plaque has happened, or plaque has been accumulating around the peri-implant region, peri-implant diseases have occurred, patient comes to your clinic with say a failed implant, how will you diagnose it? Okay. So there are certain parameters with which you have to diagnose peri-implantitis and treat accordingly. So the number one thing examination you have to do is probe. Use a plastic probe or a titanium coated probe to probe around the peri-implant sulcus region. Secondly, look for any suppuration or any exudate around the implant sulcus. Next, in the radiograph, look for any bone loss which is present. Apart from that, also look for mobility of the implants. So this diagnostic part, according to an author, can be even subdivided into presence of any plaque and calculus, probing depth measurements. Normally, the probing depth force, as usual, should not be more than 0.25 Newton centimeter. Next, presence of bleeding on probing. So when you probe with your plastic probe, there should be ideally should be absence of bleeding on probing. However, if there is a presence of bleeding on probing, then it shows us there is maybe a mucositis or a peri-implantitis occurring. Next important assessment, as I told you, is your radiographic assessment to check out if there is any bone loss. So how will a peri-implant disease look like? So as I told you, peri-implant probing should be done with the help of a plastic probe. So this is how a plastic probe will look like. So this plastic probe is used to probe around the peri-implant region. So probing depth is more around the implants than around the teeth, which is having an absence of connective tissue attachment. So this is a very important landmark to be recorded. So your probing depth has to be recorded once you place an implant, immediately, and after 6 months, and after every year. So this your basic the baseline parameter should be recorded always, and you should have it as a record, because these implant patients are going to be with you for the next 10 to 15 years. So these are some of the important things which you should remember about peri-implant probing. Also, Crena et al. Showed us that the extent of probe penetration should not be more than 1.4 millimeters above the bone level. Okay. So this is how I showed you the picture of how you can probe. So normally around the tooth, when you place the probe, you can probe around the tooth, and there might be a structure which will be hindering you from probing. So around the tooth, this, can you see this fiber component? It looks like a fiber, no? So this fiber component will hinder you from probing. In an implant, what will happen is this fiber structure is looking like this. So now see the difference in the orientation of these fibers and these fibers. This is looking more perpendicular to the tooth, whereas this is looking parallel to the implant surface. So this is how the fiber component is formed around the implant. It is parallel, whereas in the tooth it is perpendicular. That's why the supraalveolar fiber compound is a very important structure. So only when it is more perpendicular, your penetration of microorganism will be lesser. So nowadays there are modifications in certain implants which will enhance formation of such fibers rather than parallelly oriented fibers. So just some time back I told you about the probing. It should not be more than 1.4 millimeter. If you probe more than 1.4 millimeter, this is how it goes beyond the sulcus, and almost you will be see 1.4 millimeter above the bone crest level. You should stop. So this will tell you if there is any loss of fibers, and help us to know that there is an increased probing depth around the implant region. So this peri-implant probing, as I told you, should be only 0.25 Newton centimeters. So probing depth is the distance between the mucosa and the bottom of the pocket or bottom of the implant sulcus, whereas CAL is the distance between the implant shoulder and the bottom of the pocket. So these are some of the parameters which you should be able to record during your peri-implant probing. So when you talk about this implant site, you can see that this probing depth is around 5 millimeters. So this is your 5 millimeters. So this is your probing depth. Whereas your CAL is starting from the implant shoulder till the sulcus. Okay. So gingival decision is approximately 7 minus 5 millimeter, which is equal to 2 millimeters. So this is the amount of recession, peri-implant attachment loss would be 2 millimeters. That's how you calculate attachment loss in an implant. So these are other parameters, the mobility, presence of suppuration or exudate. There are indices which will help you to standardize. One is the modified plaque index by Mombelli et al. There is also the Lindquist et al. Indice which will help you to assess the plaque index. Next important thing is auscultation. So when you auscultate, there is a percussion sound which will be you will be able to hear. If this percussion sound is hypersonoric, then the osseointegrated implants are good. The implants are good. But if there is a dull sound, that is a hyposonoric sound, then the implant doesn't look good because the connective tissue is formed more rather than bone. So this will help us to find out whether the implant is sounding good or whether there is good amount of bone around the implant rather than connective tissue. So auscultation is another method to find out the implant success or survival. So once you're done with the superficial type of diagnostic parameters, that is your plaque and presence of plaque and calculus, presence of bleeding on probing, presence of exudate. Next, you go to the important parameter where you open up the flap and check out what type of a defect it is going to be. So peri-implant bone defects, according to Schwartz et al., is classified into two major classes. One is your class 1, the other is your class 2. So class 2 is the supraalveolar component. So this part above the crest of the alveolar bone. So this supraalveolar component is called as your class 2. Whereas your class 1 is the intraalveolar component. So below the crestal bone, whatever defect occurs is called as the infraalveolar component, and it can be divided into 5 classes, 1 to E. So I will explain each one. So under class 2, you have your supraalveolar component. So it is above the crest of the alveolar bone, whereas class 1 is below the alveolar bone. Okay. So this class 1 can be divided into 5 varieties. So the first variety is nothing but a buccal. So on the buccal side, can you see there is no bone on the buccal side? This can be also the lingual side. So when there is no bone on the buccal and the lingual sides, so when there is a dehiscence defect, it is a class 1A. Next, class 1B is dehiscence defect. Along with that, there will be a semicircular, there can be buccal or the lingual. Along with that, there is a semicircular bone resorption to the mid part of the implant body. That is class 1B. Next, once again, there is dehiscence defect. There is circular bone loss under the maintenance. So there will be a buccal component or there will be a lingual component. Next, class 1D is complete circular bone resorption with the buccal and the lingual bone, entire area is completely lost. Class 1E is, there is a little amount of compact layer around, but around the implant there is complete bone loss. So class 1E is circular bone resorption, but with maintenance of the, see this compact layer of the buccal as well as the oral compact layer. So coming to the radiographic features. So we saw the basic clinical parameters, then we saw the intra-alveolar defect, more peri-implant bone defects. Now we're going to radiographic features. In radiographic features, you can check out your osseointegration based on the amount of bone loss in the radiograph. So this bone loss will indicate that there is progression in the disease. So radiographic evidence can tell us whether there is a circumferential defect, which will be definitive of peri-implantitis. Apart from that, radiolucency around the implant will also help us to know that there is an overload of the implant. Radiologic classification or radiographic classification can be of 4 classes based on Speakerman's classification. There is class 1, 2, 3, and 4. So these classifications I'm explaining so that based on these classifications is the surgical part of peri-implantitis management comes. Okay. So this class 1 is a horizontal, class 2 is a patelliform. So a patella looks like a more semicircular. So this is called as class 2. It's patelliform. Class 3 is your funnel shape. So can you see a funnel shaped kind of bone loss here? And then class 4 is your gap around the implants. This is called as a gap form. So these are the 4 different classes of peri-implant defects which based on the radiograph. So based on, so to know in short, I can tell you that if there is pocket formation, if there is suppuration, if there is bone desorption, and if there is mobility, confirm it is a peri-implantitis case. However, if there is no suppuration, there is no bone desorption, there is no mobility, but you have plaque accumulation, you have bleeding on probing, then you can say that it is a type of peri-implant mucosa hyperplasia. Apart from that, if there is no pocket formation, and there is no suppuration, and there is no bone desorption, and there is no implant mobility, then you can confidently go ahead with saying that just patients having only mucositis. No need to worry about it. So this is to show you some of the numbers. The peri-implant infections ranges from very low to very high. So this range is very high based on so many factors. Okay, so it ranges from around 15.4% to 77.4%. So this is to show you that there's one important systematic review which where there were studies done from 504 literature, and they said that prevalence in smokers, can you know this number, 36.3%. So that is the amount of risk when you place a implant in a smoker. So now moving on to in short about management of peri-implant infection. So you can basically take this as a small risk assessment diagram. Okay. So when you have a diagnosis, okay, so you have to explain the patient and tell them when you have properly diagnosed it, explain to the patient, do the intraoperative reevaluation, and you can go in for a corrective phase. Corrective phase can be either surgical therapy or it can be non-surgical therapy. Next, coming to the supportive phase, you might have a maintenance therapy. So these are the most important things, okay, in your peri-implantitis management. So the risk assessment can be based on, as I told you, systemic factors as well as local factors. I'm not going much deep into it. So as I told you, cigarette smoking, more than 10 cigarettes per day is a high risk. Local factors, your surface of the implant plays an important role. Apart from that, even keratized mucosa, when it is absent, it's also one of the high risk factors. So moving on to non-surgical periodontal therapy, it can be defined as any treatment which is performed without injuring the epithelial integrity. So you're just only removing the supra structural plaque and calculus. So when you do that, it will reduce the signs of clinical inflammation, and if at all needed, it will be a preparatory phase for your surgical therapy. So this non-surgical periodontal therapy can be done by either mechanical submucosal debridement, or you can apply local antiseptics, or you can do local drug delivery systems, or you can also treat it with laser photodynamic therapy, which is one of the non-invasive and one of the very good treatment methodology. So when you talk about mechanical submucosal debridement, you can use hand instruments provided you're using titanium curettes. You need to use vector systems. We have given a very good result on removing the plaque and calculus without damaging the implant surface. Apart from that, air polishing also plays a very important role. You can adjunct it with application of antiseptics along with that local drug deliveries using various antiseptics and antibiotics. So lasers, as I told you, photodynamic therapy plays a very important role. So manual curettage is often done when you can easily debride the plaque and calculus. Vector systems will help you to give a nice hydrodynamic force, which will forcefully remove the plaque biofilm around the implants. So air powder polishing is another important innovative method to debride the peri-implant region. It uses amino acid glycine and also sodium bicarbonate. So risk of emphysema is more when you use an air powder polishing. Also, the sodium bicarbonate will lead to certain inundations on the implant surface, and it will increase the surface roughness. So these are some of the mechanical ways to treat your peri-implantitis using non-surgical therapy. So this is how a carbon curette can look like. Okay. This is your erbium YAG laser, which is used around the implant surface. And this is the vector system, which will be using a polyethylene fiber. So these are some of the rotary brushes you can use, which is made of titanium mostly. Only the exposed implant threads will be using these methods. So you can open up the flap, and then you can go ahead with these roto brushes. Next is your indication for local and systemic antibacterial therapy. So this is one of the areas which you should understand. So in case of bleeding pockets, you might have to do a local or a systemic antibacterial therapy. If there is a suppuration, apart from that, prior to any correction phase of the implant, you may probably use a local or a systemic antibacterial therapy and then going for corrective phases. I'm talking about the surgical phases. Lasers. So lasers, as I told you, soft tissue lasers also help us. Hard tissue lasers are also very useful. Soft tissue, the most commonly used ones are your diode lasers. Hard tissue lasers, mostly we use a erbium YAG lasers or also a carbon dioxide laser. But recent studies have also used Nd:YAG laser. So, but they say that do not use for disinfection of implant surfaces because it will cause damage to the sun-blasted surface, and also it will lead to certain amount of pores or some kind of ditches on the implant surfaces. So you are not supposed to use a Nd:YAG laser. Preferably an erbium YAG laser will help us. Next is your surgical therapy. So when your implant defects have been identified, as I told you, there's class 1, class 2. So class 2 is your supraalveolar, class 1 is your infraalveolar, which can be divided into 5 classes. They might involve resective therapy or a regenerative therapy. So when will you do a resective therapy and when will you do a regenerative therapy? Resective therapy will help you to eliminate the pathological peri-implant pocket, which will be there. So this resective therapy is mostly a implantoplasty type of a therapy, where you fine polish the suprastructural implant surfaces. So that will help you to have a clean field around the implant. So when the polished surface of the implant is present, formation of plaque biofilm on the implant will be very lesser. Next, regenerative bone procedures can be done when there is, say, class 1 defects, which are mostly class 1 C type, D type, and also an E type. When there is a good amount of bone which is present, when there is a contained type of a defect, you could very well go ahead with the regenerative procedure. Next, one important topic is your implant surface decontamination. This is done prior to surgical therapy. So when you do a surface decontamination with the help of a vector system or with the help of a amino acid glycine air polishing, you might be able to have a reduced bacterial load, and also it will prepare the surface of the implant for the next regenerative procedure to happen. So implant surface decontamination can be done with the help of citric acids, tetracyclines, hydrochloric acid can be used, but the most common ones are your chlorhexidines, hydrogen peroxides, and also sterile saline. You can use vector system, as I already told you, and also photodynamic therapy can be an important surface decontamination procedure. Next, the chemotherapeutic agents which can be used as a local drug deliveries are your EDTA, which is your 24% EDTA. Apart from that, you can use 40% citric acid, 10% hydrogen peroxide. So these are some of the common local agents which you can use it for your non-surgical therapy. Photodynamic therapy, when you use, you can ensure that photodynamic therapy will help you to achieve a kind of disinfection wherein reactive oxygen species will help you to clear this particular area or the sulcus area of any microbial plaque which is present. So photodynamic therapy will involve the usage of a dye which will particularly target the microbial organisms. So when they go and target the microbial organisms, and later when you irradiate them with laser, only those microorganisms will be killed, ensuring that the native tissues will be preserved. So when you talk about decision making in terms of corrective phase, will you go ahead with decontamination plus augmentation, or will you want both a resective therapy and an augmentation to side by side? So this depends on the amount of bone that is remaining. So when there is more amount of bone remaining, yes, you can go ahead with decontamination as well as augmentation because there is a contained defect. But when there is a bone loss happening, then probably the supraalveolar defect has to be undergoing a resective surgery, and the infraalveolar component or the below the crest of the bone, you will have to probably do a decontamination plus augmentation. So this is the most important thing. So you need to identify if it is a supraalveolar defect or is an infraalveolar defect. So once you identify that, if it is supraalveolar, go ahead with resective surgery. If it is in the infraalveolar, go in for an augmentation therapy. So as I told you, resective therapy will involve the polishing or you will have to do an implantoplasty, which will allow the polished surface of the implant to be maintained. So you will smoothen the exposed transmucosal component, which will minimize the plaque retention. So this is how an implantoplasty will be done. When the supraalveolar structures, you will polish those surface and you will be able to get a polished implant surface like this. So you may use diamond coated burrs for it, which will help you to polish the implant surfaces. So after implantoplasty, you have two possible methods. Either you have to surgically resect the peri-implant soft tissues, or you can reposition the mucoperiosteal flap and enhance good oral hygiene maintenance. So that is also, so how will you maintain the soft tissue is also another important decision which you have to take, whether you're going to resect it and eliminate pockets, or whether you're going to reposition and maintain good oral hygiene. Coming to regenerative therapies. So this is once again a big topic, but in short, I will be telling you that majorly in regenerative therapy, you'll be using a combination of graft as well as a membrane. So this will help you to achieve what is called as guided bone regeneration. So guided bone regeneration concept is nothing but regeneration of the osseous defect, which will be attained by the use of occlusive membranes. When you use an occlusive membrane, it will help you exclude the non-osteogenic cell population. So GBR alone cannot be giving you success. So only when you combine GBR along with grafts will give you a success rate. So most commonly for placing a membrane, you will have to use a para-marginal incision like this, not a marginal incision. So you will have a circular incision placed and a para-marginal incision like this. Yes, it will help you to have the successful placement of the implant. Once you do that, you will have enough amount of soft tissue approximation possible. So the incision will be placed like this, para-margin, like this. So once your flap is reflected, you have to go in for an implantoplasty, which is your resective therapy. Followed by that, you place a graft on it, then place the membrane. And this is how your resective and regenerative therapy normally looks like. And then you suture it. So the period of time you will be able to achieve a minimized probing depth and get a good success rate of the implant. So in short, this is the protocol which I was talking to you about. So when I told you in the diagnostic part, this is called as a CIST, which is your cumulative interceptive supportive therapy, which was told by Lang and Lin. So in which you have A, B, C, D. So this is the last part of our presentation. A is nothing but there is plaque index, which is 1, less than 1, and bleeding on probing is negative. So these are the 3 ways to classify our therapies. So when you say probing depth less than or equal to 3 millimeters, or when you can first classify, or when you can first go in to find out what is the probing depth. You find out the probing depth, say if it is 3, or if it is 4.5, 4 to 5, or whether it is more than 5. If your probing depth is less than 3, then you go in to check your plaque index next. Then you also check your bleeding on probing, and also do your radiographic examination, which will be your bone loss. So once your probing depth is less than 3, but plaque index is less than 1, BOP negative, you can directly go for A, which is your treatment. A will be nothing but mechanical debridement, polishing, and scaling. Okay, so same thing, probing depth 3 millimeter, plaque index more than or equal to 1, and bleeding on probing is positive, then also you can go for A, which is mechanical debridement, polishing, and scaling. If the probing depth is say 4 to 5 millimeter, go in for B. B is antiseptic cleansing with 0.1% Clorox gel, which will be used twice daily for 3 to 4 weeks by the patient. Next, you go in for an X-ray and also you take the PPD, which is more than 5. You can categorize into 3 types. So in that 3 types, you can either do a combination of B and C, or you can combine all the 3 together, all the 4 together. So this is how your CIST protocol works. It's basically based on your probing depth, plaque index, bleeding on probing, and your bone loss. Okay. So with this, we come to an end of this session. So as I already told you, peri-implantitis is a mixed anaerobic infection. So when you give your antibiotics, you should be able to give a broad spectrum type of an antibiotic. And you have to stage your peri-implantitis, whether it is a mucositis, it will be reversible. If it is peri-implantitis, it's going to be non-reversible, and you have to think of treatment plans based on it. Next, you have to think about the rate of progression. Rate of progression of peri-implant diseases are quite faster than that of periodontitis. Next, your diagnostic part, do a probing, do a bleeding on probing, radiographic evidence, mobility, and then you can find out and tell the patient what is the exact problem. Next is your management part, which can be the non-surgical management or your surgical management. So these are the basic things which you should understand about peri-implantitis. With this, we come to an end of the session. Thank you once again. I'm open to questions. If you have any questions, you can ask me. Thank you.
Thank you so much, Dr. Crena, for that very informative presentation regarding the management of peri-implantitis. We do have a couple of questions that we would now like to pose before you. The first question that we have for you is, what are the indications for pre- and post-operative antibiotics in implantology?
So when you talk about pre, mostly if you suggest pre, if are you talking about medically compromised, in that case a pre, or you want to give it for any surgery? If I'm not wrong, mostly any antibiotics given in prior will be due to systemically compromised or medically compromised patients. Say if the patient is having an infective endocarditis and then you're placing an implant, then you might be going for a pre-operative antibiotic. Otherwise, I don't think there is any need for a pre-operative antibiotic. Maybe you can give, in order to alleviate the stress, you can give some diazepams, anxiolytic drugs you may prefer. But I don't think so you will need any pre-operative antibiotic. However, post-operative antibiotics, yes, you might be needing, but not in all the cases. Only when there is a pre-existing periodontitis, or you have placed a membrane, or you're doing a grafting procedure or regenerative procedure, then you might be going in for post-operative antibiotics. Most probably the post-operative antibiotics which I would suggest are broad spectrum antibiotics. Yes, penicillins work very well, especially you can have a combination of penicillins along with clavulanic acid, which will be most probably augmented. Not necessary every time we need to give anaerobic infection unless and until you have a peri-implantitis. So when we talk about during placement of implant, if you're going to give post-operative antibiotics, you can very well restrict it to only when there is a pre-existing disease. Otherwise, there is no need to prescribe any antibiotics. Only a good anti-inflammatory will do in order to reduce the amount of bone loss. But when there is peri-implantitis, then you might be going in for a antibiotic session, which will be comprised of the broad spectrum antibiotics and also our anaerobic antibiotics, which will be your flagellants. Hope I have answered that question.
Thank you so much, Dr. Crena, for your response. Moving on to the next question. What are the indications for surgical debridement for peri-implantitis?
So as I told you, surgical debridement is talking about surgical debridement means maybe it's, if you're asking about resective therapy, the indications for surgical debridement will be most probably if there is a mucositis type of a defect, you might have to do a non-surgical type of a debridement. When there is a peri-implantitis, you might have to go in for a debridement, decontamination. Also, you might have to think about resective procedures. That is, I told you, the polishing of the implant surfaces. You might also have to go in for a resective procedure. Followed by that, you can go in for an augmentation.
Thank you, Dr. Crena, for your response. The third question that we have for you is, what is the protocol for follow-up of patients with peri-implantitis?
That's a very good question. So the most common protocol followed for periodontitis patients is the Merens classification. So wherein you have a supportive periodontal therapy. Peri-implant therapy also has a similar protocol. So as I told you, antiseptic cleansing, number one, is very, very important. So you advise the patient to go in for antiseptic cleansing. Chlorhexidine is the most commonly used antiseptic. Next, you can go in for a good amount of oral hygiene maintenance, which you should ensure patient is doing it regularly. Apart from that, you might also given supportive antibiotics, both systemic as well as a local antibiotic therapy could also be given. So apart from this, yes, regular follow-up is needed, maybe at 3 months initially, then every 6 months, then maybe every year. So this is how you follow up the patient. Whenever you have a follow-up, please ensure you're comparing your baseline probing depth along with the present probing depth. And whenever you're probing, I also told you, you might be using a plastic or a carbon coated titanium probes will be better.
Thank you. I think the last question that we have for you before we wrap up today's session is single-stage surgery better than multi-stage surgery in preventing peri-implantitis?
So when you talk about surgery during placement of implant, single stage, if you're meaning loading, then yes, single stage will be more preferable for the anterior implants, for the anterior sites. And for a posterior site, definitely a multi-stage will be preferable. So once you have extracted, please wait for during your extraction itself, you could probably have a good socket augmentation procedure. Wait for the good amount of bone to be formed. Then go in for your implant placement. If you do not have that time, you can go in for implant placement. Side by concurrently, you place a good amount of augmentation around the implant. Then wait and then go in for your loading at the second stage. Yes, multi-stage is definitely preferable for posterior implants, especially for the posterior maxilla. However, the mandible, if there is a good amount of torque, primary stability which is achieved, you can go in for a single stage surgery also. So that will kind of prevent peri-implantitis depending on the site and the amount of bone. Hope I've answered all the questions. Thank you.
Thank you so much, Dr. Crena, for making time for this presentation and for providing us with some very informative and very interesting clinical information regarding peri-implantitis. To all our viewers, thank you so much for being a part of this session. We will be back with another clinically relevant session on dentistry next week. See you soon. Please take care and happy dog plexing.